Good evening, everybody. Despite the heavy traffic, I think you made it. And many of others are online, so I think we are okay. So I'm going to talk about a new molecule, Aviptadil. Well, it's a synthetic radioactive antisense peptide. It's a naturally occurring peptide which has been synthesized now. There are 28 amino acids. I will not get into the structure of that. Important thing is 70% of this medication, when you give it, it concentrates into the lungs, which is where it is supposed to act. Very short half-time, half-life of 1 to 2 minutes, so it has to be given as an infusion and mostly eliminated by kidneys. And here you can see that most of it is concentrated in the liver, in the lungs, hardly anything in the heart, hardly anything in the liver. And this is pulmonary artery hypertension. It's been used extensively for the last many years in PAH. Okay, it acts through VPAC1 and VPAC2 receptors in the lungs. It shares the receptors where the COVID-19 virus also acts. It has 4 primary effects, which you will realize was anti-inflammatory action is the most effective. It reduces the pro-inflammatory cytokines, interleukin 1, interleukin 6, tumor necrosis factor alpha. It reverses the CD4 to CD8 ratio. CD4 normally in the inflammation it increases, so it reverses the ratio. Reduces the pro-inflammatory cytokines, increases the anti-inflammatory cytokines, and natural FKB, it blocks the production of tumor necrosis factor alpha. Then, most important, from ARDS point of view, it increases the surfactant production. So if you remember from our physiology, pneumocytes 1 and alveolar cells 2, so it increases the production of surfactant by alveolar cells 2. By a mechanism I will not get into. Methylcholine is incorporated into phosphatidylcholine. I will not get into mechanism of action of how it works, but it does increase production of surfactant. It also inhibits apoptosis. So programmed cell death is reduced in the alveolar cells, so restructuring can happen better, healing can happen better, and it preserves the pulmonary tissue, which has been shown experimentally. Also, the caspase activity is reduced, so cell death is reduced. So these are the 4 mechanisms by which it works in the alveolar cells and its effect on the ARDS. So this is a diagram of how it works. I will not again get into that, but basically it acts through the VPAC1 and 2 receptors, produces anti-inflammatory mediators, so counter the pro-inflammatory cytokines. Okay. Also, it has indirect effect on the dendritic cells and the macrophages. Release of cytokine production is affected, so pro-inflammatory cytokines by the macrophages is reduced. The Th1 cell proliferation is increased, while the helper T cells differentiation is reduced by this. Co-stimulator activities increase, the regulator T cell activities increase, and the pro-inflammatory factors are reduced, chemokinic factors are reduced, cytotoxicity reduced, and regulatory T cell activity is increased. So it rebalances the CD4 to CD8 activity. So basically, the imbalance between anti-inflammatory and pro-inflammatory cytokines is, with the dysregulated response which you see, is restored, and also the regulatory T cells and the helper T cells imbalance is also restored. So as I said, in the alveoli, the surfactant production is increased by the type 2 cells. It also reduces the damage to the type 1 cells, so restoration of exchange of oxygen can also happen. Again, as I said, apoptosis or cellular death is reduced, helps in preservation of pulmonary tissue, and prevents NMDA-induced caspase-3 activation, which damages the alveolar cells. Coming to COVID-19, if you all remember, the spike protein works through the ACE2 receptors, it will attach itself, and this also works through that. So in addition to the effects which I already talked about, it significantly reduces viral replication of COVID-19. So that's the added benefit of that in COVID-19. So as I said, it reduces the pro-inflammatory factors, it has been shown to increase survival. Monocyte also activation is impaired in this, and epithelial cells are preserved. What are the countries which have approved this? Well, India, it has been approved for COVID-19, but ARDS because of COVID-19. If you need to use it for ARDS, which is non-COVID, I normally take a consent from the patient. I'm sure DCGI will approve it for ARDS very soon. In US, it is an orphan drug designation for ARDS, that means non-COVID also. It has been approved again for orphan for pulmonary arterial hypertension since 2005. So PAH, it has been used for a long time. How does it work in PAH? Well, basically, it also, in addition to the other effects, it also reduces pulmonary pressures. Okay. And orphan again for sarcoidosis in 2020. European Union also approves it for acute lung injury, which term is not used anymore, and for sarcoidosis. Georgia, I will not talk about. So this is where the countries, which are the countries where it is approved. So primarily it is approved for COVID-19. It is approved by some countries for non-COVID ARDS. It is approved for sarcoidosis, and it is approved for pulmonary artery hypertension. Okay. Now let's look at the evidence. ARDS with COVID-19, add on to the standard of care. Obviously you have to give the standard of care. It was a randomized, multi-center, double-blind, placebo-controlled trial, good number of patients, 150 participants over April to October. And classically, this drug for adult patient, you need to give 1 vial on the first day, 2 vials on the second day, and 3 vials on the third day. So it is very easy. For idiots like me, it is very easy to remember how much to give. You don't need to really calculate the dose for anybody over 60 kilo. So this is what the standard administration, besides the standard of care. All patients had severe respiratory failure by standard definition, and this was an addition to the standard of care. So primary endpoint was resolution of the respiratory failure, and secondary endpoint was improvement in PF ratios, any adverse effects were noted, and 7-point WHO scale for respiratory distress or COVID-19. At all time points, day 3 to day 28, the patients who had met the primary endpoint, most all time points. Okay. So patients have Aviptadil 2.1-fold odds of being free of respiratory failure, that means no oxygen requirement. This was more marked, 4 times more marked in patients who had severe respiratory failure. And recovery time was 7 days earlier, from 14 days to 7 days. So that was a significant saving. Okay. Secondary endpoints, higher proportion of patients shifted to the milder clinical state from the severe clinical state. 7-point scale, again, till at 28 days also, significant improvement. WHO 7-point ordinal scale improvement at 28 days also. Reduce the risk of death by 20%, which is a fairly good number. There was a significant improvement in PF ratios compared to the placebo. So all the secondary endpoints were also significantly met. And this was a consensus statement. Many authors, but basically V.K. Arora, you may be knowing, and Agam Vora is the secretary of Association of Physicians of India, is a pulmonologist from Bombay, well known, and they have also recommended that this has possibility of being used. Let's look at some Indian data. Now this is a ARDS. Let's look at the 7-case series. Okay. So this was a case 1, 50-year-old male, but these are all from different parts of India. So I am going to tell you about which part of India also it is from. This is from Bhimavaram Hospital, ARDS with 50-year-old male with ARDS with sepsis and MODS and type 2 diabetes and 3 successive doses. All of them received 3 doses on 3 days. PF ratio was 50, improved to 200 after the therapy. PO2s improved, FiO2 came down from 100 to 40, PEEP came down from 20 to 5. Significant improvement. PEEP requirement decreased, patient was discharged. Case 2, you can see the X-rays here, and after therapy you can see the X-ray improving here. 82-year-old male, this is Sterling Hospital, Ahmedabad. After aortic valve root replacement, pretty big surgery in an 82-year-old man. Again, patient had ARDS, so they gave Aviptadil. After the first dose of Aviptadil, drastically improvement in oxygen requirement, reduction, improvement in oxygen saturation. On day 3, patient was off supplemental oxygen. Day 4, patient was discharged. So dramatic improvement in an 82-year-old man. This is the third case, young boy, 17-year-old, left middle lobe bronchopneumonia with ARDS. I have no idea where this is, Gedda Hospital, but it's some other part of India, I suppose. Karnataka, okay? Yeah, all right. So patient was on mechanical ventilation, standard of care was being administered, given 3 doses of the drug. First day of admission, saturation was 72% on room air, revealed severe ARDS, mechanical ventilation support. 4th day they started the drug. 5th day, marked improvement, FiO was reduced to 80%, patient's condition had improved, he was given a CPAP trial, tolerated well, so patient was weaned off from ventilator on 6th day. 7th day was stable, saturation on room air. So pretty dramatic improvement. And here you can see the X-rays. This was the first one, first and then third at discharge. Absolutely clear. FiO2 was 50%, came down to 40%, PF ratio 100 to 480. Dramatic improvement in the oxygen requirement. This was a 64-year-old man from Vadodara, moderate ARDS, hypertension with large liver mass, SATs were 83 to 88, Aviptadil begun. PF ratio 80, saturation was 88, PF ratio was 127, improved to 199, FiO2 came down, PEEP requirement went down, date of the patient was discharged from ICU in hospital. Case 5, again 80-year-old man from Vadodara, ARDS, mild ARDS, hypertension, diabetes, dyslipidemia. PF ratio not available, but saturation was 96. FiO2 was 50%, came down to 30%, nasal prongs. Patient was discharged from the ICU in hospital. Case 6, 64-year-old man, St. Thomas's Hospital, Chennai. ARDS, probably Trelly or whatever. SATs were 80. PF ratio 130, improved after therapy to 475, discharged from ICU in hospital. So pretty dramatic again. Case 7 from Aurangabad, Maharashtra, 32-year-old man diagnosed ARDS with CKD. He was saturation was 60%. PF ratio was 80, that means severe ARDS, improved to 240, patient got discharged from the hospital. I'm not trying to say these are the case series which they published. Some patients may have died, some patients may not have improved. Not it is 100%, no drug in this world works on 100% of the patients. So let me be very clear about that. But this is the series which they published. And we had this case, I have used it in many, many cases. And along with me, the other pulmonologists also using it. Dr. Kuleria also is quite, uses it quite frequently. So this was a classic case. There was a 24-year-old boy, fever and sore throat for 7 days, abdominal pain, shortness of breath. Came to us, nothing of these. Diabetic, detected 1 month back, hypertensive, 6 months, took some homeopathic medicine, presented to the emergency room. Moderately built, tachycardic, tachypneic, 88% saturation on non-rebreathing mask with high flow oxygen, hypotensive, so he was in septic shock, bilateral Krebs. Patient was intubated in the emergency room and shifted to my ICU. And this was what the X-ray looked like on a ventilator. When I saw on the rounds, patient had a saturation of I think 80 or 78 on 100% FiO2 with a PEEP of 15. He was borderline hypotensive, and we turned him prone. And I told the people, my colleagues there, that please talk to the family. He's a young patient, we should do everything what we can. Offer them ECMO, and if they agreed, that's what we should do. I had bronchoscoped him before turning the patient. Unfortunately, the patient did not agree for ECMO, probably financial reasons or whatever. So these were the investigations. I was not expecting the patient to survive the next morning when I came for the rounds. So these were the numbers. As you can see, CRP was 156. Otherwise, not really. Urea creatinine was high. PCT was not very high. So COVID was negative, Vidal was negative, malaria was negative, leptospirosis, scrub typhus, dengue, everything was negative. Hemoglobin A1C 12.1, echo was okay. So he had a community acquired pneumonia, probably tropical, acute kidney injury with uncontrolled diabetes and ARDS. We started broad spectrum antibiotics in view of the diabetes and all, and doxy to cover for any tropical fever. We empirically gave Tamiflu also because viral fever was happening at that point of time. I have two colleagues of mine who just walked in, pulmonologists. All right. And we gave gram-positive cover, and along with that we gave some antifungal also because this was a young patient and poorly controlled diabetic. So as I said, he was in prone position, he was required, PF ratio was 80, he was an FiO2 of 100 and PEEP of 15. So before turning, we had done a bronch on him, and we were desperate. Aviptadil had just come, and I said there is nothing, no harm in using it, let's try it. So we gave him. So this was a day 3 X-ray. X-ray actually better than this. This is because of the LCD projector, which it is not showing. He required proning 3 times. Noradrenaline was stopped on day 3. Again, pneumoslide was negative. Respiratory PCR showed nothing. Mycobacterium negative. Pneumocystis negative. ANCA was negative. CMV was negative. Everything was negative. Well, fungal culture 1 came positive. Candida tropicalis, which is not unexpected, but he had staph epidermidis, which was sensitive to everything. So it was covered with the teicoplanin anyways. The patient was continued on these antibiotics. Tamiflu was discontinued, got extubated on 6th day and discharged on 10th day. So this patient, no question about this, dramatically the drug worked in this patient. And this was the X-ray on discharge. Now this is the Indian experience of doctors. This is the older, a large number of patients, 336 patients here. Patients given was 637. This was the number of doctors. Pretty good ratio, I would say, 1 to 2. Okay, but all over India they've used it. Let's look at some international studies. Okay. Now this guy, Yusuf, has published a lot of papers from, I think, Dallas, Texas. Okay, so to assess the efficacy and safety of Aviptadil in ARDS related to sepsis, 8 patients with ARDS, 7 out of the 8 patients survived. 1 patient died, he died because of stroke, not related to this drug. Patients had multiple comorbidities, they were given standard of care. So this was patient 1. This was the baseline tumor necrosis factor alpha, TNF alpha reduced. FiO2 was on admission, it was PO2 was 84, FiO2 was room air, PF ratio of 150. This patient survived and no side effects. This was patient number 3. TNF alpha fell after administration of the drugs. This was the baseline FiO2 90%, PF ratio of 50. So these were severe ARDS, critical ARDS, and this patient again survived, and possibly hypotension. So that is a known side effect of this drug. Patient number 4, again TNF alpha fell. This was the baseline, FiO2 was 70. This patient also survived. He had seizures, but which were not related to the drug. Patient number 6, again TNF alpha fell. So TNF alpha fell in all the patients. His FiO2 was 50%, but PO2 was only 86. PF ratio was 172 at baseline. He also survived. He had seizures, but again not related according to the committee, safety committee. Number 7, again TNF alpha fell. This was the baseline, 90% FiO2. This patient also survived, and no side effects. Patient number 8, again TNF alpha fell. PF ratio was less than 100 to begin with. This patient also survived. He had a hypotension, which was probably related to the drug, most likely, and he had a pneumothorax, which was obviously not related to the drug. Okay, patient number 5, the data was not there, but baseline FiO2 was 70%. This patient survived. He had bigeminy, which was probably related to the drug, and he had diarrhea, which again was likely because of the drug. It's a known side effect of VIP. Patient number 2, FiO2 was 80. His life support was ultimately withdrawn. This data was not there, so he remained refractory hypoxemic. How does one administer it? As I said, first day you give 1 vial over 12 hours. For an average patient, you give it over 12 hours. Second day, you give 2 vials, again for 12 hours. And third day, you give 3 vials. And that is a whole therapy. 3 days therapy, and then you stop it. It can produce hypotension. I'll come to that a bit later. So this is different weight, body weight, but most of the Indian patients would fall into this category. And as I said, by escalating doses is because it's a vasodilatory drug, and you have to look at whether too much of hypertension doesn't happen. That's the reason it is given. It is mostly concentrated, as I said, 70% concentrated in the lungs. Contraindications, well, as any new drug they say, any allergy to any of the contents of the drug. But undesirable side effects, well, there's known effects is vasodilatation. That's why it's given over 12 hours. And most of the times you give IV fluids, it will correct itself. Then it can produce diarrhea. Again, that's a known side effect of the drug. It can produce diarrhea. Infusion-related reactions, there are no case reports of overdose. So nothing else. And facial flushing and nasal congestion can happen because these are all known effects. These are not side effects. These are effects of the drug. So thank you very much for your attention. And I'm quite happy to address any questions if there are any.
The one problem that we faced while using, this is a technical problem. Basically, they suggest that it should not be diluted with 5%. It should be used as such. So giving 10 ml over the period of 12 hours, sometimes the infusion gives alarm repeatedly because it assumes when the flow rate becomes so slow, the pump thinks that it is not going. So repeatedly that goes. So is there any way out how to
use better syringe pumps? That's what I would say. I mean, it does not normally. We haven't found that. No. Would you like to address something?
Which phase of ARDS it has a maximum role, because ARDS passes through within 14 days, most of the fibrotic event starts taking place. So how early and what period we can use?
See, I would say, I would use it early. Once the patient is in the ICU, at least he'll have moderate ARDS. He'll be oxygen dependent or whatever. So I would use it at that point of time. Why to wait for longer? It has really no major side effects. And although the studies have shown that more severe the ARDS, the better the effect. Some of these patients were on ECMO. Of the American series, there were 4 or 5 patients on ECMO. Except one, everybody survived.
What about using it in an early stage? Because these all are such inflammatory and protective for us.
So that's what I'm saying. Use it early. Why to wait? Once the patient comes to the ICU with the ARDS diagnosis, there is no harm in using it.
Viremia, initial phase of viremia also we can use it.
Yes, you can.
Day 1 to 5 like
At least in COVID-19, it has been shown to reduce the viral replication.
Okay.
I don't know whether it is effective for other viruses or not, but COVID-19 is established, reduces the viral replication. So mechanism is the same. Through the messenger RNA, the replication is reduced. So the possible it will reduce that.
Markers which can help select because it must be costly.
I don't think it is that costly. Would you like to answer that? I really. It's not very costly. No, that you don't need to do. You don't. See, if you have to do markers, I would say do CRP. It's a cheap test. But otherwise, markers are not really necessary. Now, how many of us, to be honest, will be able to predict that this patient is going to get worse? ARDS. Really, there are no absolute criteria which will tell you that this is. You can say he is getting worse. But prediction of which patient mild case will become moderate or severe, you can't say that. So that is the reason for your question. That whom to give it? I would give it.
All these patients which were, so they're all pulmonary ARDS. Extrapulmonary ARDS, none of these patients.
No, it has been used for extrapulmonary ARDS also. It has been used for extrapulmonary ARDS also.
So if it is being used, then do we simultaneously use steroids also in COVID patients, COVID ARDS?
Yeah, it was primarily approved for COVID ARDS.
No, so I was asking if we are using this drug for COVID ARDS, do we simultaneously give steroids as it is indicated in COVID ARDS?
Standard of care should continue.
So because the mechanism of action.
That means oxygen dependent COVID ARDS, you will give steroids.
So since both of them have the same action in a sense that.
They will have the standard of care and then you add this drug for any therapy.
So, thank
It's
you,
been used also for a patient after lung transplant.
Yeah, so,
Developed ARDS, some time after, not immediately post-op.
So I have a couple of things. Thank you for presenting the data very lucidly. See, coming back from things like for orphan drugs, let's talk about orphan drugs as a whole. And I also like to put something like a Dotricocin alpha many years back, which came, we all used it, and one day it went by, it's vanished, right? So whenever these new therapies, and I think we have all had our share of using these therapies in second wave of COVID. I think no critical care pulmonologist would have not used, because we're all trying to fight an enemy which we didn't know anything, and whatever was available to us was being used, and there were multiple things which were used, and I think we all can vouch for it. Some worked, maybe they worked, or if they didn't, we don't know. Now, this Indian RCT which you're mentioning, do we have a data how the crossover was, how this randomization occurred, was it compared to the placebo? Because we all have treated patients for the RDS with standard of care, and they have improved and have gone back. So, for cases, I'm fine. I will also use a young guy whom I think may gut feel. Like you rightly said, there is no marker which will say this patient will get better, this will not. We always had patients where we could have used, they still improved, where we felt and they could not afford a therapy, like ECMOs, for example. We don't have ECMOs, we tell them, still patients make it and they go back. So, taking from Dr. Jaiswal's question, is there a sort of an algorithm where you would place, because if we put everything early, like hit hard, hit early, then probably that may not be answered until we have a placebo-controlled trial. So do we have, Rana, any placebo-controlled trial as such internationally?
No, they have. The American trial is placebo
for
controlled.
ARD, because these are all case series type of randomizations. They are, but placebo controlled, I don't think, I have not read. Secondly, this is a drug which has been tried in inhaled route in COVID, and they have shown that inhalation therapy of the same drug actually can prevent COVID ARDS, right? Because of all the data which we showed. And that was the reason in sarcoid, it is not an IV drug, it is used in inhaled form. So, looking at all that, probably I would be more inclined that if we have a sort of an inhaled preparation, which is probably acting at the surfactant level and all that level, maybe that may actually help once we have a placebo control. So my questions are more to do with standard of care alone versus standard of care placebo, standard of care Aviptadil, because that will clear up, because it's a wonderful thing, it's not very costly. That is going to be something, but because it is not costly, we start using it in every potential ARDS which could worsen. I'm not going into what cause of ARDS, because finally it is going to go into the lungs and it should work for any reason. It may be a non-pulmonary ARDS, it should work by the theory. But I think that is something which I would, when I look through the data, I still would want the pharmaceutical industry to go back and probably go for a randomized placebo-controlled trial. That would clear up many doubts, and it's a wonderful drug if it actually stands the test.
No, they have a randomized.
I would like to see that.
They have an RCT.
Because
American publication was an RCT. It was randomized, it was blinded.
Patients, do we have the stats for that?
Yes, sir. We have that full text article. Actually, your
It's not presented, no? That would...
actually that folder that we have given you, it is the full text article is there itself. This is a randomized control trial, RCT. RCT, yes, sir. That is a multi-center RCT. That is a multi-center RCT, sir.
Let's go through that.
Yeah, please go through it.
The thing is, the number was 74, 74.
Correct. Equally divided.
No, which is not a bad number.
See, that's
far as the
because I read there, I said, let's see those
Yeah.
stats, because that would actually help us be more convinced than case series where we give on gut feeling.
Good number.
Yeah.
Actually,
That is a very good number.
Sir has rightly said that international trial and Indian trial both are the same randomized control trials.
Right.
Okay, now, wait, if there is something more demanded, we need to wait for a meta-analysis.
The Chinese will start working on it. This you are allowed, this is not to be left here, you can take it home.
It is to be tried and seen.
I would think so. I am quite, because this boy, at least I can say, I would still agree that all the patients, it's not worked. But many patients it has worked, and this boy, it was a dramatic save. And I attribute it entirely to this drug, because I didn't even think that he was going to see the morning.
In all the cases, there was dramatic improvement on day one, means immediately after. So does it mean that if it doesn't improve on the day one after, within a day or so, there is no point in continuing in the treatment for the next 2 days?
I don't know.
Sir wants to share his experience. Hello.
Responders like responders and non-responders.
In the
That's
last
what it is.
week, I received a patient with bilateral pneumonia and what's like TLC was 36,000, bilirubin was 5, creatinine was altered. Patient received with SpO2 of 60%, blood pressure also 60/40. And I work at Nilkant Hospital, so we have a small setup. So we were thinking to shift that patient. And then it came to me that I am a physician, I am not a pulmonologist. So I started this. Next day patient improved like hell. Like on third day we discharged that patient. The earlier we were thinking that we are going to lose this patient or patient will go on ventilator, like that. Like on after 48 hours, like
Yeah.
There is magical, like you can say. Thank you.
See, one caution is if the patient is hypotensive when you are giving this drug, you have to keep that in mind, that you need to maintain the perfusion pressure. So maybe give a... right.
Sir, as far I know, ARDS, there are two trials which have shown mortality benefit. That is the ARMA trial, low tidal volume, and prone positioning. These are two RCTs which have shown a mortality benefit. According to this studies, which say 20% mortality benefit, which even have not been shown by the Prosiva and the AR, then I think this drug should be in a game changer. But it's not in any, if somebody says 20% mortality benefit in ARDS, that's a huge number. Even the Prosiva trial, ARMA trial have not shown. Those are the standard of care randomized. So I think if this is the thing, then it should have been a game changer.
No, probably it requires more randomized controlled trial, as you rightly pointed it out. I am not denying that. There's no question about that.
It's a cheaper therapy. Probably Indian medicines getting made in here, so it's easily available.
You will not have issues regarding that. So I think this is something which we should be probably seriously looking at. ARDS is something which is very, very common, and if given early, I think definitely we every year, especially in Delhi, in Delhi NCR, we see tropical fevers coming with severe ARDS who have real bad prognosis, young people. And I think if this can be given at an early stage, probably before the first organ shutdown, I think that's going to be brilliant.
Yeah, see, you talked about activated protein C.
Yeah.
The number needed to treat in that series, that drug, for that drug was 16. That means you treat 16 patients to save one life. Here it is 1:5, and NT is 5. So if that is correct, then it is dramatic. Yeah. So that's what needs to be looked at. So thank you.
Any other question?
We can discuss.
Any other question till now? Maybe you want to ask something?
Yeah.
Discuss it. Thank you, sir. Thank you.
Thank you, sir. Thank you, Dr. Yatin, for the excellent presentation. You have really made our day. And thank you all. And I'll request each one of you. I'll request you all to please join us for dinner. Thank you.